Over the next few minutes, I will introduce you to a new concept, a technique, and a simple product, the projector, which can dramatically alter the way in which you perform endodontic procedures. The orifice of the root canal lies on the floor of the pulp chamber, deep within the coronal structures of the tooth. Visual and physical access to the orifice is obstructed by those coronal structures and by prominent marginal ridges of adjacent teeth. Often, endodontic procedures are complicated by severe coronal breakdown, which compromises the ability to obtain ideal isolation. Virtual projection of the orifice from the chamber floor to the cavo surface of the access cavity would offer direct and unimpeded visualization of and access to the projected orifice, while also providing quick and reliable isolation. The resultant simplification of otherwise complex endodontic procedures would significantly decrease treatment time while rendering a more superlative clinical result. Canal projection is particularly useful in management of the curved canal, the canal obstructed by separated instruments or calcifications, the perforated furcation or the perforated root, the retreatment case, whether simple or complex, as well as in the isolation of teeth with severe coronal breakdown. To understand the technique, consider the single-visit treatment of this mandibular molar with a large, cariously undermined alloy buildup. Note significant subgingival caries invading from both the mesial and the distal. Conventional endodontic access is created and defective restorations are removed. In this case, a non-cutting tapered Rotopro burr by Ellman is used to loosen by vibration and to unscrew old TMS pins. Of course, all remaining caries is excavated. All orifices are identified and dimpled with a number 2 slow-speed round burr. An appropriate matrix system is applied. Since the anticipated projection material is an injectable resin, in certain cases, such as the one in this demonstration, a sculptable matrix material such as Cavit G is particularly useful. Segments of Cavit may be overlaid on the defective surfaces and bimanually swaged into the desired contour using 2 alcohol-saturated cotton pellets in locking cotton pliers. All bondable surfaces are etched and primed. Files which will insert well into the body of each canal are selected and prepared with projectors. It is important to work the projectors on the files such that they will slide freely on the flutes. The prepared files are inserted well into the body of each canal. It is generally advisable to use a different sized file for each orifice so as to be able to differentiate which file represents which orifice as the procedure develops. The paramount importance of enhanced visualization must be stressed at this point. The ability to actually see the file tips as they enter the respective orifices is critical and cannot be reliably performed without the benefit of magnification and enhanced illumination. While any level of magnification and enhanced lighting will improve the clinician's ability to perform these procedures, at least 3x to 4.5x and 4,000 foot candles of head-mounted illumination is recommended. In this demonstration, designs for Vision 10X surgical telescopes and the Quadralight 6000 enhance every aspect of the procedure, including the careful inspection and measurement of files and the reading of radiographs. After the files are placed securely into their respective canals, a cotton plier is used to slide the projectors apically on the files until they seat precisely into the periorifice dimples previously created. Once the orifices of the canals are occupied by the files and projectors, bonding agent may be applied to the prime surfaces using a small disposable plastic pipette. The bonding agent is then distributed over the primed surfaces with a blast of air, and auto-polymerizing composite buildup material is immediately injected using the AccuDose needle tube bicentrics inserted to the chamber floor and slowly withdrawn while injecting to prevent the formation of voids. The cavity is completely filled to the cavo surface.